Well, good afternoon, everybody, or good morning, wherever you are. Wound Care Guy here, Doug the Wound Care Guy, and I got another episode for you. We're gonna do an episode on why wounds have odor. Why do they stink? And this is quite a problem for people. I just want to let you know that it's my pleasure to once again bring this information to you in my humble quest to help a few people out. I think this is a great. I love YouTube for this because a regular guy like me out in the middle of nowhere can help somebody like you that maybe needs some help with some wound care ideas. And stinky wounds, they're terrible, right? No one wants a stinky wound. So we're going to talk about why wounds put off odor in the first place. I'm going to have a little sip of coffee. Got myself all dialed in today. Anyway, we're going to talk about why they put off odor. We're going to talk about the emotional effect it has on the person with the smelly appendage and some of the feelings and or concerns that the caregiver will have as well, right? Because you're in it together. You got somebody with the wound, and you got somebody trying to take care of that wound. And if it's your loved one or your neighbor or whatever, there's going to be some concerns, and we're going to go over those, okay? So first of all, we want to talk about why wounds stink. So it happens too often. Your loved one has a wound. It's been there for a while. It's chronic. Dressing hasn't been changed in a while. Maybe you slept a couple of nights extra. You guys didn't change the dressing, and you pull off the blankets, and oh, there it is. Oh, there it is. Odor, right? And it's like, woo! And you look around for the dog, make sure it's still alive, right? It's back, and you're like, good Lord, can everyone smell me? Is my leg infected? Is it going to fall off? These are real feelings and real concerns that people have, and in my practice, I've heard them, I don't know, at least 100 times, right? Over the years, I think I've probably heard that 100 times. And until you actually put a video together, you don't really, you hear what they're saying, right? But when it comes time for me to educate on a subject such as this, there's more time for reflection, and I understand it now. I can't again. As a matter of fact, I had a nightmare once. I had this one patient that had a very, very chronic wound. It had been around for years, people, and this individual had a wicked wound, and it was much of the leg. And I had a nightmare that I had a wound just like that, right? Oh God, it seemed completely real. I'm sure I felt like when I woke up in the morning, I knew for certain that there would be a wound there, and so I guess it does infect me on some levels as well. So the question is, why is there an odor in the wound, right? And if in a word, we're looking at bacteria. Bacteria is in the wound, and it's putting up an essence. And what they do is they get into your wound. They set up shop. They make the wound their own. They need a house too. They need a place to live, right? And so they set up shop, and they begin to release enzymes into the wound bed. And those enzymes, when they reach into that wound bed, they kind of break down the wound like a kind of bunch of loggers going into a forest, cutting away at the trees. That's kind of what happens when these enzymes are released from the bacteria. The enzymes get released from the bacteria into the wound bed, and begin breaking down, whatever tissue they come in contact with, soft tissue, muscle, skin, fatty tissue, whatever it is that they come in contact with. They set up shop in that stuff, and as soon as those enzymes get released and they kind of get a process going, you're putting off more odor because, first of all, you have more breakdown in your tissues, and you're getting that enzymatic digestion in the wound, which releases the gases, and those gases begin to permeate, and that's what you smell. So obviously left unchecked, these bacteria begin expanding their operation and begin breaking down more tissue within the wound bed, compounding the odor, and ultimately they can move into good tissue, right? That's their concern. You leave them just kind of do their thing, and they go into good tissue, and then that's when you can get an infection. The host, meaning you or the person who has the wound, is the one that's kind of trying to fight this bacterial invasion in their tissue, and and so they're the ones that are going to be suffering, right? They're the ones that are going to be providing fodder. So left unchecked, these bacteria begin expanding their operation and begin breaking down more tissue within the wound bed, compounding the odor, and then ultimately they could move into good tissue surrounding the wound, and that's when an infection ensues. The good news is it's likely that your wound isn't infected, right? It's probably just an abundance of bacteria in the wound. And we're going to talk about how to take care of that, right? So I guess the obvious question then is, well, where did the bacteria come from? And I've had patients in the past that have had E. coli in their wound, and it's a delicate conversation to tell them how it got there. And there could be any number of reasons, but it's kind of in the shower, and it's kind of gut bacteria that winds up in a foot wound. You can kind of do the math on that. So where does the bacteria come from? Well, it comes from the patient. It comes from the skin, the perimeter of the wound, and the gut, as we talked about earlier. Well, where else? Well, it can come from the caregiver's hands. It can come from stuff in the house, bedding, same old shoes that someone's wearing, the shower, kitchen, dog, whatever is in and around the patient potentially is a vector, which we call sort of whatever creates a bacteria gets into a wound. We call it vector, and so anything can be the vector, right? So that's of course why hand washing is super important. So wound care guy, are there any other sources of odor? I'm glad you asked. There sure are. Other sources of odor can be the wound drainage, and we talked about it earlier in our example that it's been a while since that bandage has been changed, and drainage will get onto that bandage, right? And inside the drainage, obviously, is microscopic particles from the wound itself, bacteria, etc. And of course, that's going to be a source of odor as well, right? So changing a bandage obviously will get rid of that particular source of the odor. Let's see here. So I think another sip of my coffee would be good. Hope you all don't mind. I've got some instant coffee going on today. Just wanted something a little bit fast to put together and keep something. It's really, really cold here today, and we just got through one heck of a winter storm. Matter of fact, took me some time today to put everything back together and get my internet up and running once more. So I thought, well, heck, I'm going to just go ahead and shoot it out and get this done today for you guys. And I got later on in the day than I thought it would, and by the time I'm shooting this, it's in the afternoon already. It's starting to get cold. The sun's going to go down soon. So I thought, well, I'm going to have myself a little coffee. However, that means I'm probably going to be up half the darn night. So that's going to be a bummer. Anyway, there are also some kinds of bandages that can cause odor or precipitate odor, and that would be a foam bandage, for example. A foam bandages, especially the silver bandages. We'll get into that toward the end. We'll talk just a little bit about silver bandages. We're not talking about bandages by and large today. We're just going to mostly talk about why is there odor in the wound, right? But silver bandage can help with that, and we'll elucidate that fact. But nonetheless, there are many foam bandages out there, and some of them don't have silver in it, right? And they're just foam. And foam, there's a thing called an occlusive dressing. An occlusive dressing is a dressing that you put onto a wound, and like sometimes you'll see, the name escapes me right now, darn it, but it'll be that clear white, completely clear bandage, and they put it on skin tears quite frequently. It's very, very thin. It's not porous. There's no gas exchange or movement of anything in that particular type of bandage. It is called an occlusive bandage for that reason. And same thing goes with foam to a lesser degree. There'll be some vapor removal or relief from the foam bandage, meaning vapor will leave the wound, right? And because that way, it's not, just getting, moisture just sort of sitting up against the skin and sitting up against the wound, sort of contributing to the problem, right? So the foam bandage isn't completely occlusive. It does allow the vapors to pass through it, but sitting on there for a long period of time, you get the drainage buildup. And you've got that drainage buildup, and it's going to stink. After 3 or 4 days especially, it's going to stink. Mind you, some of these bandages can stay on for up to a week, depending on the level of drainage. Obviously, if you have a gusher, you're going to change the bandage more frequently. You change the bandages in accordance to what kind of drainage you're dealing with. If you're dealing with a lot of drainage, you're going to have to change the bandage frequently. That's just the way it goes, to try to reduce the odor, right? Because you're going to get that, you're going to have that bacteria and that funk that's on that wound dressing sort of just sitting there, and that's going to be stinky, right? But so back to the foam bandage and the occlusive bandage, those will contribute to odor. So it could be bandage, yeah. So a lot of people will say, and I hear it all the time, hey, when I was, younger, I had these wounds, and, on and on they go, always about being younger and having wounds that didn't stink or heal, right? And that's kind of the deal, right? As we age, we get some bad habits. Maybe we smoke a lot. Maybe we drink a lot. Maybe we love sweets. Maybe we don't get enough exercise. Maybe we're, have other problems such as being wheelchair bound or whatever. And all of those factors contribute to wound healing. So if we do have, we have a couple of years on us, and when I say a couple of years, folks, I don't mean like, you're 35 or 40 years old. And some people can meet that demographic. They have a lot of things they're going wrong with themselves, even at the age of 40, unfortunately. But by and large, we're looking at people that are probably into retirement or well after retirement, and they've got some, life. We break down, right? And sorry for the bad news. I don't like it either, but that is kind of what happens. And so those kinds of things can contribute to what we call a chronic wound, right? And I elucidated some of the ideas or some of the conceptual things about chronic wounds and how to clean a chronic wound in my wound cleaning video, so you might want to look into that. It's more of a deep dive on how to clean a wound. This is more going to be talking about sort of why does a wound stink, right? Some of the parameters why wound stinks, or why wounds stink. But chronic wounds, are something that's been around a while. So typically speaking, we'll go back to that. I'm a young person, and I used to heal up really fast. Well, when we're young, we do heal up fast, right? When we're young, couple of weeks, got a scab, and another couple of days go by, we're in the shower or we're doing whatever. Maybe we just do like this because it itches a little bit, and poof, it pops off and there's skin there, right? That's what happens when we're young. When we're old, not so much. If we have some disease processes or underlying conditions that move everything kind of into the situation of being a chronic wound, then we have a different set of circumstances. We have a chronic wound. And so I was just checking my battery because I'm like, oh my God, I had this thing. I thought I had this charged, and certainly it is, but it freaked me out because I didn't quite see it. But there you go. So, the life of a YouTuber, right? Which I think I'm going to dig. I'm going to dig this, you guys. All right, so chronic wounds, they typically have more odor. That's why we're going to talk about a chronic wound. The reason they have more odor is because they've been around a lot longer. There are processes within the chronic wound that prevent it from healing, right? And the number one thing, of course, is this sort of buildup of bacteria in the wound from, maybe not the best cleaning cycle. So that's one of them. Chronic wounds typically have more odor than wounds that were more recent or even surgical wounds. Why? Well, since a chronic wound has been around a while, the wound has undergone some changes that promote the production of more bacteria. And when a wound produces more bacteria, it stalls out. The wound can't go through the healing process as well because the bacteria are causing it to slow up, right? They're causing some things that happen down in the wound bed. Basically, they're kind of elbowing out any good tissue, consuming the good tissue, things of that nature. And they like to hang out in a wound bed that doesn't have a lot of oxygen to it. So that's why we want to clean those wound beds, okay, folks? Clean that wound, man. Get that bacteria out of there. So, get back to I have this all typed out, right? And, it's I'm going to have to get some kind of a little deal in the front here so I can look at the camera. It kind of bums me out that I can't do that, but I'm kind of low tech right now, so give me a, that's why I got a prop, right? Got my prop. So back to the wounds. Since a chronic wound has been around a while, the wound has undergone some changes that can promote the production of more bacteria. The bacteria can then break down more tissue, leading to more dead tissue in the wound bed, an increase in drainage and more odor. This, of course, stalls wound healing and lends to the chronicity of the wound. Chronicity, doesn't that sound like a rock band or something like that? What was that? Who? Let me think. Yeah. I forgot the guy's name now, though. Anyway, we'll come back to that maybe if I can remember it. Okay. Most of you guys probably wouldn't remember that guy. I can't remember him either, though. Let's see. Anyway, so worse, we're coming back, Jack. Worse, the bacteria can set up a biofilm, folks, on the wound. All right? A sort of bacteria microcosm of multiple bacteria, multiple species of bacteria. And you want to think of that as a sort of a bacterial universe, right? A bacterial apartment building. We're talking layers, strata of different species of bacteria within that wound bed. And what that does is it creates a sort of protective layers in that wound bed to protect the bacteria. And what it feels like when you hit a biofilm is it's very slippery. And I think when a wound comes in, I can pretty much tell that it's got a film to it. It'll look dullish, almost I'm not going to say purple. That wouldn't be purple, but it's kind of like a dull sort of membranous kind of a look, and then when you touch it, it's very slick. And in fact, the skin, the perimeter of the wound can be very slick too. You can just sort of feel it. It's different than a wound that doesn't have, I don't know how to describe it. It would be like, well, it'd be like if you had a table and you were rubbing your fingers on the table and without anything on it, and then you took a little sort of, just a little tiny bit of cooking oil maybe, and you put that on the table, and then you rubbed your finger over that. It's almost like that. It's very slick. And you can imagine you take an instrument or something like that and you're trying to clean it, you're not going to get it off. That's the problem with it. And we're going to get to more of how you deal with that as soon as I get through this other stuff here first. So I do have a format here, it's trying to follow it. But the reason I got to write this down is because I'll go off on a tangent. I'll start telling you about who knows what. I can go on, and you're going to be like, honey, get me a coffee or whatever. This guy's yakking and yakking. I like to yak. I'm sorry. Anyway, I'm going to try to have fun with this thing because I'm new at this. So the last couple of videos were like a little too on the serious side, and I wasn't quite used to what I was doing yet. But I think I want to try to find ways to have fun with this channel. And you know what I thought about doing? You guys can let me know in the comments what you think. Is I was thinking about just taking some shots around the farm, going out and taking some pictures of chickens and all my little critters that I got going around, and maybe a couple of projects I might go, just a quick little boom, get it in there and kind of do a wound care channel / homesteading. I don't know, maybe, right? That sounds fun, I think. I kind of like the idea of it. Anyway, back to why wounds stink. So this biofilm, what happens is that this bacterial universe, antimicrobial cleansers don't really get at it. And what happens is, as a consequence, is that the bacteria proliferate, right? They've got a party going on. And what happens when they got their party going on is the wound stinks more, right? And because you can't get the antimicrobials down to the area, these bacteria, they're not affected by your wound care. They can't be. And so, it's really, really hard to get that out, get that out of the wound. So how does this make the patient feel? And I was thinking about that. What would it be like to always be, have this odor, right? Everywhere you go, you kind of stink, right? And so, and then you got this caregiver, right? Look, some of you out there might be a patient. Some of you out there might actually be a caregiver. My heart goes out to you. Trust me. That's why I'm doing this channel, so that people have some kind of idea what the heck to do about this stuff, because it's spooky. So you got the caregiver, and the caregiver feels kind of helpless. And, you're in this circular pattern of, hey, it's not really working out, folks. And it turns out that I did a study about this, of course, right? You got to do a little study. And it turns out that at least this one study that I looked at suggests that smell or odor from a wound is the second worst symptom a person can experience other than pain itself. And pain is pretty gripping, right? It's pretty bad. So the next one is odor. So we're dealing with something significant here for people, right? So that's the second most concerning symptom. Patients with wound odor are often very embarrassed about how they smell. Patients can often smell their wounds when others are not able to. Remind me of a comment that a girlfriend of mine once said, that a fox can smell its own hole. And we'll leave it at that. But clearly, once you kind of sort of get used to your own odor, you're going to be very, very hypersensitive to that, right? And you're going to be hypersensitive to how people are reacting, perhaps. Some people might be completely oblivious, and that's great. It's probably the best place to be. But some people would be really concerned about it. Probably, I don't want to go gender there, but I'm sure that women are really concerned about that. They could probably smell that pretty badly. One of the problems with the big picture is that if somebody has an odor, they start wanting to not leave the house. They start not wanting to leave the house. They want to stay in their in their comfort zone. They want to stay in their PJs, hang around the house. The odor can lead to a negative body image, right? It can lead to anxiety, depression, and deepening social isolation. And I just think that that's terrible. I really hope that, I hope this helps somebody. I can't imagine having deeper, social isolation where it's just sort of propagating on itself, kind of like the biofilm, right? So the biofilm's kind of propagating on itself, and then you have these series of social concerns that sort of, lock you away, and keep you away from people so that you don't have to deal with the discomfort of having odoriferous emanations. And then it brings along the fragility of the human condition. I remember one time I had a wound. I was in the hospital. I was in the hospital for a week. I had a chest wound. I had a chest tube in me. And I got released from the hospital, and this was prior to me being a wound care person, right? Because now I've been doing wound care I had done some wound care, but I hadn't done wound care daily. Now I've been doing wound care daily I kind of lost count, but it's been over 15 years. I go by the amount of times I have to recertify for wound care, and that's been 4 times. So maybe up to 20 years by now. I'd have to do the math, honestly. That's not my forte anyway, but... and I'm going off on a tangent, of course, but I did have a wound, right? And the nurse didn't really kind of communicate what was going down with the wound. It was over here on my chest. And so I remember getting out of my truck. I didn't have any groceries in the house. I had to stop and get some groceries. And I was by myself, and I got out of my truck, and I guess my arm must have come up or something like that. Anyway, my bandage fell right out of my shirt. And I remember the feeling of panic, because I'm like, is there going to be blood squirting out, or guts or whatever? Is there something coming out of me, or is something going to go in there like a fly or something? I was like freaking out, and so that's how I relate to the idea of that fragility, right? That human fragility. Like if you have you see that some, I don't know how I could describe it anymore. Hopefully you guys can kind of get the idea of what the human fragility is all about. It's just, it's like that whole precious life thing, the fleeting life that we have in a way, and how easily it is that we get hurt, how easily that our life can become shattered. And I don't want to go off on a tangent on that, but that's something that person's kind of taken in, and it can become a focal point. And many times I've had a patient tell me, "Oh my God, is my leg I'm afraid my leg's gonna have to get chopped off." Well, I've had many patients over the years, and they all have some level of concern about losing their limb, and I think to myself, well, I'm despite my best efforts, people have lost limbs, right? And I take that very, very personally. As a matter of fact, sometimes I think about what is it that I'm doing, because oftentimes I'm dealing with chronic wounds, and so I'm at the, let's say I'm at the legs, right? It seems that I think the bulk of the wounds that I've treated over the years have been below the knee, mostly below the knee. Obviously, we get wounds in other locations. Blood flow becomes an issue below the knee for sure, because it's the furthest from the heart. I think that's pretty much what we're dealing with, and that the fact that it does seem that we do get a lot of vascular injuries and what have you in the legs as well. So that contributes to these wounds, and so I thought years after year, I'm like, wow, man, my problem is not the foot or the leg that I'm working on, it's the mouth. I have to take care of the mouth. The stuff we're putting in our mouths, folks, is what's causing our wounds, more or less. But that's another tangent. We don't want to go into that. I'm probably going to do one on nutrition at some point in time. I do believe I'd like to do something like that. I think I will, because nutrition is huge. It's a huge factor. So kind of anyway, back to people, who are feeling like they're going to lose their appendage. It's a serious concern. I get it. I was using that example of coming out of the hospital and having that sense of, just like mortality, that, just because a bandage fell off me, I freaked out. It was spooky. Plus it was a cold night. It was getting dark, nobody was around. It was just like, yeah, it was a wicked feeling, the whole I'm alone feeling, kind of a thing. And so, people do worry about losing their toes and what have you from a stinky wound. It's on their mind, more than we think. Just wanted to bring that to bear, I think. Hopefully I closed that loop completely. We're going to go on now. And then again, you have the caregiver feeling that they're doing something wrong, that they'll get feelings of inadequacy. They've been doing everything they can, try to help this person's wound heal. There's guilt, right? The guilt gets in there, maybe you guys start to bicker a little bit, or, patient care is difficult, right? You're dealing with somebody who wants to try to be comfortable, but they're not. And you're trying to do some wound care and getting them into a comfortable position, and they've got all this stuff, right, that's bugging them. And so you have to kind of go through layers and layers and layers just to get to the wound. The problem with all of that, of course, is that then if you get into that bickering thing, then there's potential there that your wound care routine will break down. The routine, that's what we want. You got to have a routine with wound care. It's got to be. The big picture when I do wound care is that I look at the wound. Is it dry or is it wet? Do I have to bring moisture to the wound, or do I have to control the moisture? And that's going to set up your cycle of how you're doing your wound care. The next thing that's going to set up your cycle, obviously, of course, is how much drainage. It does me no good to see a patient once every 4 or 5 days if they're blowing through their drainage in one. So that's another consideration, which we'll get into. I'm going to break down the bandages, right? I'm going to go through each kind of bandage and talk about them a little bit more, like, like those transparent ones. I still can't remember the name of that. That's going to bug me. But anyway, the foams and what have you, and the gauzes, and obviously gauze is a lot less expensive, right? It's a lot less expensive, but it's like it's not even the Ford 100. It's like the Ford Courier. No, there's probably some souped up Couriers out there. I'm sorry about that, but it's the gauze suits a purpose. I wouldn't throw the baby out with the wash water on that, but there's a lot better dressings for wound care these days than gauze out there. So the question is, what can be done about the circumstance of the stinky wound, the kind of runaway situation, the patient's getting more and more sort of depressed about the situation. The caregiver's like had it. Right? Maybe you're on another caregiver. Maybe you've had 2 or 3 caregivers by now. That's a real thing. They go through the caregivers. It doesn't jive. There's something that's not jiving, right? And so they might go through caregivers. So what's the big picture there? What's the next step with this? And so what I'd like you to do is I'd like to have you bring your primary care person in and communicate these concerns. I try to be an advocate for patients. Patients go to go see their doctor, and nowadays you got 15 minutes. You're like in and out. You're like if you're super cordial, your visit's over with by the time you get through the salutations. And so I say, hey, look, write down your concerns on a piece of paper. Try not to get throw it off into a tangent like I do, and you sort of have a breakdown of the flow of information that needs to occur from the primary care person. That's a big deal. So write down your concerns on a piece of paper. But you want to get in contact with the primary care provider, get some good advice, right? Maybe get referred somewhere if it works for you. Obviously, this channel is not to take you away from your doc. It's to supplement your physician. It's to supplement your primary care person. So that you have some knowledge base, and you have you can ask good questions. That's what this is about. I don't want to try to take away from your physician. That's just nothing. If you're stuck somewhere if you're on the moon, okay, take my advice. It's good advice. I have good advice from years and years and years of working with wounds, technically working with wounds, right? And trying different things out, different bandages on different kinds of wounds, and not everything works for the same person, right, or the same wound. Like I might have Joe Blow from Kokomo with one particular type of wound, and I might have somebody else over here with the similar kind of wound, but the whole situation is different, right? The whole situation is different. Maybe this person over here, they're allergic to adhesives, or they're allergic to iodine, or they're allergic to whatever, and that's going to alter the care that they receive. This thing is going in and out of focus. I'm telling you, I'm running into a lot of weird problems today. All right. So what you want to do is you want to ask your primary caregiver for a culture. Well, what is a culture, wound care guy? I knew you were going to ask. So I thought I'd just step to it. A culture is where you pull this little swab out of a container that the container is sterile, and it's got a little cotton swab on the end of it, and we were trained to do a little zigzag move over the wound, and sort of it's like taking a cross sampling, zigzag across that wound. You're getting a cross sampling of what bacteria might be in that wound bed. And what happens is that culture gets sent out, and it takes about a week for the whole thing to happen. And they put the culture is introduced into a petri dish, and they've got like some sugars in there and stuff like that help the bacteria grow. And they identify what kind of bacteria ultimately that you have. That gets communicated to your physician, and the physician may decide to give you some antibiotics. Antibiotics are systemic. They address bacteria systemically. So if you're noticing that the odor's getting worse, the drainage is getting worse, pain's getting worse, there's erythema or redness or heat around the wound, you're starting to get to the situation where systemic control measures such as an antibiotic is going to be probably very beneficial for you. And a lot of physicians don't like to give out antibiotics. There's antibiotic resistance, and I understand the concern. Many of them don't see the issue with a high amount of any kind of like staphylococcus or whatever in the wound as being particularly would require an oral antibiotic because of resistance. But in some cases with a chronic wound, that is a really good choice. That and then picking up good wound care, and that's what we want to talk about, right? So they get the Petri dish. You're on the oral antibiotics. Now you have great opportunity to really do some vigorous work on that wound and get it right. I always tell everybody, if you have some great antibiotics on board, that you could probably walk through a well-used pasture and not get another infection. Barefoot, that is, right? Barefoot through a well-used pasture and not get another infection. I'm going to go ahead and lean up a little bit. It looks like the camera's kind of going in and out of focus, and I don't know why that's doing that, but I'm trying to get through this video with you guys. So yeah, you want to start busting out some good wound care, right? Get that antibiotic going. Or guess what? They just might have some kind of a treatment idea for you. They might have a topical antibiotic or an antimicrobial idea. Once they get, your results from your culture. There are certain antimicrobials that work better for certain types of bacteria. Vinegar, acetic acid, works really great for. It's going to escape me. Pseudomonas. Pseudomonas. And you can tell Pseudomonas. Pseudomonas has an odor to it. And the dressings will get yellowy green. That's how you know you got Pseudomonas. And acetic acid works really, really good for that. I have a couple of techniques that I use to... Contact time is a big deal with antimicrobial cleansers, right? A good cleanser, you put it on, you squirt it, you have a little conversation, and then you want to sort of rinse it off. You don't want to be in a big hurry to get those off, because some kind of contact time is really good. It's beneficial. It helps kill more bacteria, right? It's a longer presence. But anyway, that's an aside. So you get the antimicrobials going, you get the antibiotics going, you get on a good cleaning schedule, you start interrupting the propagation of the bacteria. And interrupting the propagation of bacteria relies on frequent enough wound care dressings or changes in the wound care dressing and the use of antimicrobial cleansers to interrupt bacterial cycles, right? Because they're propagating. I think I read somewhere it only takes 10 hours for a biofilm to reassert itself after a cleaning. That's pretty sad. It happens very fast. Biofilms are wicked. They need to be scraped out. That's what I suggest. We'll talk about that going forward. So, cycles. If you find that you're cleaning a wound every 4 days and the wound still stinks, you have to take your dressings into consideration. But if the wound still stinks, go to every 2 days, right? Go to every 2 days and see if that interrupts the bacterial cycle enough to reduce. What you're trying to do is you're trying to chop down the amount of bacteria in that wound without, you're never going to kill all the bacteria in the wound. So you just kind of cut them down a little bit, cut them down a little bit, cut them down a little bit. Let the host, which is the person with the wound, the hostess with the mostess, right? Let their immune system sort of get engaged a little bit too. You just need to push the wound, into the benefit with these other measures that the hostess with the mostess can also use their immune system to fight some of the bacteria in the wound. Obviously, if they have a disease process, that makes it a little bit more difficult, but we're not going to get into that just yet. So you just want to get into a good cycle. Start picking up a good antimicrobial antimicrobial dressings, and get the drainage under control. Drainage is also a function of increased bacteria. So if you got a lot of bacteria, you're going to get a lot of drainage. If you have a wound that all of a sudden starts turning a little bit, doesn't look so good, got a little bit of odor to it, different kind of an odor maybe, you get a little bit more drainage, you got probably some bacterial colonization in that wound, right? And you're going to be getting closer and closer to perhaps, a biofilm if you don't have one already. So persistent non-viable tissue in the wound will cause, it'll cause odor. You get the microscopic particles from the wound on the dressing, it's going to stink. So frequent cleaning of the wound needs to include physical removal of non-viable tissue in the wound so that you have remove the decaying tissue that produces the odor for or food for bacteria. So you got to scrape it. You got to scrape that wound when you're cleaning, and we'll go in. You can look at my wound cleaning video, and it talks about that. Now, we didn't get into sharp debridement so much on my wound cleaning video, but I'm going to talk about that in a second here. But that's how you get the bacteria off. Also, with washing hands, I'm going to probably repeat this as many times as I need to. Again, you're going to do your ABCs, 30 seconds, clean your hands really well. Pull the bacteria off with the towel. Caregivers, please. That's how you're going to do it. I have people all the time, man, with really yucky fingers. Like, they don't clean their fingers, and their nail beds are dirty, and they're long. I hate long nails. Like, long nails are terrible for people with chronic wounds. What do? The wound itches, they scratch it. Who knows what they've scratched before? They might have scratched behind the dog's ear. They might have scratched their backside. They might have did like this in their ear. Who knows what they did? And it's all getting underneath these the nails, under the nails. And you just, if you're itching a wound or whatever, you're breaking the skin open and you're introducing all this bacteria right into the wound. We talked about it earlier. Where does the bacteria come from? A lot of it comes from ourselves. We move it all over the place. So. Man, was that a side tangent or what? So left unchecked, bacterial numbers grow. They colonize the wound. You think, what is the word colony? All of a sudden you got a heck of a lot more of them, whatever they are. And, you'll start out with a wound being 25% colonized, and then it moves to 50% colonized, and then it might move to 75% colonized, and that might be 100% colonized. So that means you're like many of whatever type of bacteria, tens of thousands of bacteria in the wound. And the wound, man, it can't make it. It's got too much bacteria. It's too much waste material. The wound surface becomes, anaerobic, meaning there's less oxygen available, which creates a very, very wonderful environment for many bacteria. They have a party, they propagate, boom, diggity, diggity, boom, diggity. You got some biofilm development going on there, okay? You got to interrupt it. So, scraping it with a piece of gauze, not to cause blood trauma. And again, we're gonna go over that. We already went over that in the wound cleaning video. So check that out. Okay, check that out, because it's an hour long. Okay, not too many people want to look at it. It's an hour long, and it's amazing that it went that long. I don't know how it did, but it did. So if the vicious cycle persists, you may want to seek the professional help from like maybe a surgeon or a physician that doesn't mind doing sharp debridement, or physical therapists. They have wound care. That's my world. And we do sharp debridement and remove non-viable tissue out of the wound. Surgeons, they go after it, man. They'll get you down to a brand new, beautiful, beefy red wound bed. And there's a lot of argument between the professions as to how one would deal with that. As a matter of fact, I've used maggots once. I did maggot therapy, and it was just once, and it was pretty cool. And the maggots did a beautiful job, and they're very selective. So they really only go after the nastiest of nasty dead material in the wound bed. But surgeons do a beautiful job too, but they're not selective, and they'll take everything and the kitchen sink. That's kind of okay in a way, because what happens is that, especially if you're getting good wound care, if you're in a situation where you got this nasty wound, it's kind of been neglected, you didn't know what to do about it, weeks have gone by, you're way into the chronic phase, it stinks, critical colonization, you name it, you got the whole ensemble going on, you don't want to get carved on by a good surgeon, get down to a nice good material, and then not have a plan. You got to have a plan. So you start out with the idea that, hey, look, I'm going to need a little help. I've got this biofilm. Now I'm going to go see a surgeon or a physician. They're going to clean it out. Sharps. They're going to take it. They're going to, you know what I mean? They're going to go down in that wound bed and clean it all out and remove all that material like a dozer going through, right? Kind of a steamroller or whatever going through there and getting rid of that biofilm, getting rid of that bacteria. Really a full-on assault of that stuff, right? That nasty stuff. And then what? You got to go home and you have to have a plan. So you want to make sure you have your bandage selection down and what kind of topicals you're going to put on it. Kind of start thinking in those terms because you're given a new lease. That wound's given a new lease. We talked about processes within the wound bed of a chronic wound, and what happens is the chronic wound, for lack of a better term, kind of goes to sleep. It doesn't have that vigor. It's kind of like pruning a tree, right? Or a bush. Sometimes we prune a bush, and that happens to be one of the things I do love to do. I learned how to prune trees from a great man who was a pear farmer. And I was looking out at the trees once, and they're really beautiful the way that how they work. And I said, "Man, how do you do that?" And in just a few minutes, he taught me how to prune. But what happens when we prune a bush or something like that is we get a flush of growth, right, at the tip of what we cut. And that's the same thing for a wound. It's the same thing for a wound. If you get sharp debrided, you're going to stimulate the heck out of that wound. You've moved it all the way out of the chronic phase and back into the acute phase because you have all the vigor of a trauma, right? A trauma, a brand new trauma that your body can figure out what to do with. And if you got a plan, you can keep it clean and you can really accelerate the wound growth. But make sure you have your nutrition in place too. Hydration, amino acids, vitamin C, zinc, things like that. Make sure that you've got that dialed in too. Get on a good schedule. Get your helpers going on. Make sure you got good dressing selection, right? So that's kind of where sharp debridement will take us. And it gets rid of that biofilm. And it gets rid of the odor. The odor's gone after that because all that dead stuff's causing the odor. But if you have a wound that's not getting a lot of oxygen to it, the odor comes back, right? And that's kind of the thing that we experience in diabetic ulcers because they've got a lot of destruction and also arterial. Well, most ulcers really, they kind of stink after a minute, but diabetic ulcers really do stink very bad. And they do have a reduction in blood flow, typically speaking, because diabetes causes hardening of the arteries. And smoking causes blockages. And these things can reduce blood flow and oxygenation to that wound bed, and that's going to stink, right? But nonetheless, you can still get it to heal with good intervention. Some exercise. Exercise is great, and just get on a stationary bike and start kicking it. Obviously, if you have a wound on your foot, you can't really do a whole lot of walking, but, a walking routine beforehand is great, right? An ounce of prevention is better than a pound of cure. We went to the sharp debridement. We talked about the acute phase, bringing the acute phase back, bringing the cascade of wound healing processes, nutrition, back to the wound that the chronic wound lacks. This is going to physically interrupt the propagation of bacteria in the wound, gets the wound off to a nice fresh start. So, we've talked about dressings a little bit here, and there are dressings that do a beautiful job of reducing odor. One of my favorite is Iodosorb, but of course I didn't prepare for that, but I have to mention it because it's really a very, very good dressing for odor. It's matter of fact what they pride themselves on, and it does do the trick. And it's an iodine based, right? Iodine based dressing. It's a paste. And kind of looks like baby poop. Sorry, kind of gross, but this is a wound care channel. We're allowed to be gross. I can eat a sandwich and do a wound care job. I'm sorry. I've gotten used to it over the years. But there are others. We had talked about earlier about silver-based dressings, especially with ionic silver. And what happens is that if you put a foam dressing that's got silver, or there's other types of dressings with silver on them. Anyway, you got a silver dressing and you put it on the wound bed. Whatever dressing comes in contact with the wound, that's called the contact layer. So that's on there. And what happens is drainage will go up, especially the foam or alginates. The dressing, drainage goes up into that foam, right? And it's up there. And what happens is that the ions the silver ions are positively charged, and they kind of come out, man, and they go after the cell structure of the bacteria, and they break down the cell wall, and then they kind of go in and sort of attach themselves also to the proteins inside that inside that bacteria, and it causes those proteins to denature, and they can't replicate. So that kills them, right? But if you got a biofilm, you're going to need help. Guaranteed. You got to get that stuff off there. But it's great. Foam dressings are great. I absolutely love them, especially with the silver in them. Probably hands down I've got two favorite dressings, and we'll get into those later on. But I do love how that works. Most of the bacterial killing occurs inside the foam bandage itself, but some of it can leach down into the surface of that wound bed and also have a similar effect. The other one is honey, medical grade honey. And medical grade honey is a beautiful, beautiful thing that God gave us, right? And the medical profession kind of hijacked honey. It's like thousands of years old that people have been using honey. And as a matter of fact, silver went back to the Revolution, or I guess was it the Revolutionary War, or anyway, when early on, it's a few hundred years anyway, that at least that we've been using silver, probably longer than that. As a matter of fact, I heard that you used to put silver spoon, real silver of course, spoon into food, and let it before refrigeration, and it would keep bacteria down in it. So for what that's worth, I don't know. I wouldn't try that at home. If you got a refrigerator, go ahead and use it. But the medical honey placed to the wound has many effects. First, the honey can kill the bacteria through desiccation. So it's got an osmosis thing going, and the I guess it's the sugars inside that honey molecules suck. They need moisture, right? So they suck the moisture literally right out of the cell of the bacteria, causing it to desiccate, right? So it dries it out and kills it. And then the contents of the bacteria spill out into the wound environment, and there's proteins and stuff like that, and they get dried up. So there's no replication. Honey also reduces the pH in the wound, reduce the likelihood of propagation, because the honey will lower the pH of the wound bed. And so this makes it a difficult environment for them to live in. And also through some enzymatic action within the wound, medical honey, got to say medical honey, right? All honey actually will work like this. Okay, that's kind of what I was getting at. Is you could probably get some store-bought honey if you were in a pinch, but there are other things that go on with these new this medical grade honey. Like one of them, I think I can't remember the name of, but it somehow it gets to where the bees are using a lot of leptospermin, which is a plant that has some cytotoxic properties, or astringent properties, I guess I should say. Antimicrobial properties for sure, right? So leptospermin has some antimicrobial properties to it, and this addition to the honey, the honey, the bees are essentially selecting the leptospermin plant, and therefore some of this leptospermin is getting into the honey. That's the idea. But honey by itself will do these things that I'm talking about. So also through an enzymatic process, I guess it's probably some digestion. The enzyme activity in that wound bed will begin to reduce or release low levels of hydrogen peroxide into the wound, and we all know what hydrogen peroxide does. It's kind of like this rapid fire dehydration of cells. So my mother put hydrogen peroxide on anything. So she everything was hydrogen peroxide with my mama. Yeah, she loved the stuff. But if you're on a desert island, and a lot of physicians don't like people to use hydrogen peroxide, but I say don't throw the baby out the wash water. If you got nothing else and your wound's getting funky, the reason they don't want you to use hydrogen peroxide is if you got beautiful red tissue, You don't want to put hydrogen peroxide on it. It's just going to blow it up. But if you have nothing but funky tissue, or it's, the wound just occurred, it's great, to clean it out and reduce the bacterial load in the tissue. So if you don't throw the baby out with the wash water, right? We get nuanced. It's not great for good granular tissue, right? It's bad for good granular tissue. It kills it. Cytotoxic. That's what they call it. Some of these dressings can be made available, or they are available online, and I've talked to some people that they've gotten the dressings at their local pharmacy, over the counter. I guess they bought them, so they're pricey, but a silver foam dressing, if you have a low exudating wound, it'll last a week, so it's kind of worth it. And again, foam dressing does a lot of great stuff for wounds, which we'll get into later on in another video. And it has been my experience that if you do have a wound that can easily get infected, you got to err on the side of caution. If you want to kill the microbial and invaders, the bacteria in the wound, and that your host doesn't really have a great immune system, like you haven't really dealt with that nutritional aspect of that wound, which is huge. The mouth is everything for the wounds, right? And you're going to want to clean it with something that's got some firepower. And that's where povidone comes in, or Dakin solution. Dakin solution is kind of like a bleach water mixture. There are certain percentages for different kinds of wounds. And that's all available to you on the internet. You can find out how to make Dakin solution yourself. And it's, 0.25% Dakin solution. I think I've read, I don't think it's very, very cytotoxic. Povidone I've used many times. And I've seen granular tissue grow beautifully. And again, granular tissue is going to grow in the absence of what? Bacteria. If you're kicking butt on that bacteria, granular tissue can grow. Granular tissue is really important because that's your basement of your wound, and that's how you're going to get it to fill up, and that's how you're going to get the tissue, the skin tissue, to grow over it. That's part of wound closure. The longer a wound's open, the more likely a person's going to get infected and possibly lose the toe, foot, whatever it is, right? So povidone and Dakin solution will really tip the scales in your favor. Those are my outcomes. Those are what I've, over the years have found to be helpful for me. Now, you might be working with somebody that doesn't really believe those things, and that's fine. They might have different experience. That's my experience. I'm sharing my experience with you. Again, I'm not here to, kick your doctor to the curb. I encourage you to have a great relationship with your physician. The only thing that I'm trying to accomplish is get some information out there, some good educational information about these concepts, about these wound issues, right? Because not everybody can get to a physician. And I think probably in the future we're going to be, everything's going to be online. People already are having, I think I was reading somewhere it's going to be essentially a 30% increase in the amount of people that do virtual visits with physicians and their caregivers, nurse practitioners, etc. I hope that doesn't go that way with massage therapists, because that would be terrible. But Reiki is kind of like that, right? Probably do some distance. Woo! Sorry for all you Reiki people out there, or if it's Reiki. Anyway, I was just being silly, obviously. So again, I'm not trying to take away your medical provider or usurp them or move them out or malalign or anything like that. Work with them and develop a plan. And so I'm just trying to give people some tools, right, to help yourself. Okay, well, that's all. Have a great day. Bye-bye.